Thank you for reviewing my case study presentation. I will be covering a brain perfusion study done at my clinical site, which is Banner University Medical Center in Phoenix. Brain perfusion studies, they indicate whether or not there is cerebral perfusion. With brain deaths, a lot of the times people are in comas that are irreversible. There's either a known or a suspected cause of that. Usually, if the person is brain dead, they don't have any brainstem reflexes and no respiratory function, as well as that coma being irreversible. The brain perfusion study is a non-invasive way for us to tell whether or not the cerebrum's getting blood flow. And it's important for certain medical decisions, like if life support needs to be discontinued, this would be one of those tests that would help in making that decision. Or if the patient is an organ donor and they need to decide whether or not they need to go ahead and discontinue life support to go ahead and donate those organs as well. Now, there is neurological testing that they can do, or EEGs, that will help indicate that as well. But sometimes if those tests are inconclusive, this is a good addition to make those decisions that need to be made. At my clinical site, we use Neurolite for our radiopharmaceutical for our brain perfusion studies. There are a couple different ones that are available that are technetium-based. There's Neurolite, and there's also Tech 99 HMPAO. Those two, they cross the blood barrier. And then they have other ones that don't cross the blood barrier, like DTPA and sometimes use pertechnetate. For our Neurolite protocol, we use 20 millicuries of the Neurolite, and we administer in a IV. Now, it's preferred if you can get peripheral line access, but for this specific case, we actually had to use a central line because that was the only IV available. The imaging protocol in our department for this study is going to be a flow that is 2 seconds per image for about 30 to 60 frames, which is going to be about 1 to 2 minutes of the anterior position with the cranium in the center of the field of view. You're going to do a blood pool static after for about 500 K counts, and then the rest of your images are going to be about the same frame that first one took. Now, when it comes to getting the lateral images, we're moving the head towards the respirator so that way you're not moving it away from the equipment that they're attached to. And then we finally take an anterior image, including the chest and head, for our last image. We have 4 cameras in our department, and when we do brain perfusion studies, we do them on our Philips skylight that's pictured in here. It's really cool because you can pretty much have your patient on the gurney. You don't have to transfer them to a bed. The bed seen on the picture actually has wheels, and we actually keep ours just moved to the side, and we always do our imaging in that camera with the patient on their bed already. It's a lot easier, especially in this type of case where the patient is pretty much comatose and we've got a lot of equipment coming in with them, and we have a nurse usually with them as well as a respiratory team. So it's easy to just clear the room, make sure that there's room for everything, and then the 2 camera heads can be adjusted with a remote control. They go pretty much the entirety of the gantry, which is pretty much almost the whole room. So it's really good to maneuver around, especially if you're trying to get like a lateral and your patient, like you can't move the head exactly all the way to the side. So that way you can adjust the angle and get a proper lateral. Since it is a technetium product, we make sure that we have a low energy, high resolution collimator and a 20% window centered about 140 keV. Some imaging complications that can occur usually result of like lack of communication or lack of preparation. When you get these patients coming down with transport, usually there is a nurse or two along with a respiratory person there. It requires communication with multiple teams, just making sure everybody has the correct expectations of how the scan's going to go. You're going to want to make sure to communicate with the nurses, finding the proper IV access, making sure you have a good IV. Because you are doing a flow, you want to make sure you have everything prepared. You want to make sure that your imaging room is prepared as well. And, because the patient is coming down with a respirator usually and a bunch of equipment, you want to make sure you have proper access everywhere to make sure that you can get your patient under the camera, which is kind of why we use our skylight, because we have so much room in that room for everything to go in and to get proper imaging. And you want to make sure that you're properly doing your flow, making sure you're starting the camera at the right time so that you don't miss any information. But yeah. So there's not too much history associated with my patient due to the reason of his admittance to the hospital. 21-year-old male with head trauma from self-inflicted gunshot wound to the head. Unfortunate case, unfortunate situation, but something that's all too real seen in the hospital setting. So the complementary images that go along with the brain perfusion scan images that we took in our department are the CT images. The CT images are kind of cool because you can see the ventilator actually in, and you can actually see the bullet as well. And the patient was wrapped in a compression sleeve of some sort that had a zipper, so you can actually see a zipper artifact in the images as well. This is a sagittal view that I was able to get. It is showing the bullet right in the center. You can tell it's a very dense material as compared to any of the other material in the body, other than maybe the zipper that's out there. Because of that density, it is showing up super hot white on the images because they're outside of the window width. This is the coronal view that I was able to obtain for the CT. And here is an axial view that I was able to find of a slice with the bullet in it. The bullet is just so dense that it is just causing a streak artifact. The next two slides are the final report done by the radiologist who read the CT. If you'd like to read it, you can pause the video. I'll leave a couple seconds between slides just for viewing. But basically, the impression of the report is that the gunshot wound was a right to left transit through with skull fracture. It fractured the skull coming in. There was pneumocephalus, which is the presence of air or gas in the cranial cavity, and multiple intracranial fractures and hemorrhages, including finding blood in the ventricles, and there was a diffuse cerebral edema with loss of definition of the basilar cisterns as well. So these multiple fractures are significant, and there was orbital trauma as well. And now to the nuclear medicine images for the case that was done in the department. Here is the flow images obtained. You can't really see it because of the positioning, but it was done through a central line. You can kind of see it a little bit on the bottom of the first few images. You can see regular physiological uptake in kind of the top of the lungs that you can see on the bottom, as well as the vascular structures and the nose. There's that hot nose sign. As you can tell, the brain's not lighting up. This is a better indicator of the central line that I was talking about. You can see it pretty clear in this blood pool image. You can see the hot nose sign, you can see the lungs, you can kind of see the eye sockets a little bit in there, just the shadow of them. And here is our right lateral picture that we took. You can still see that line being really hot in there, but you can also see the lungs, not really seeing a hot nose or anything with that, with this view. But as you've seen with the previous pictures as well, we're not seeing any cerebral uptake at all, so no cerebral perfusion. And this was the report that our reading physician had done from the study after we provided him the images to look at. Pretty much the essence of it is there is no brain perfusion. The impression is listed as an abnormal blood-brain barrier imaging study with no solid scintigraphic evidence of brain perfusion. And then pretty much just saying that he alerted the nurse that was in charge of this finding. Because our reading physician actually doesn't work in the hospital too often, he'll come in on Thursdays to do ablations. Pretty much all of our interaction with him is over the phone. So we process the images, we send them in packs, and then he reads them. For these types of studies, he gives us a stat reading, so we let him know that the perfusion study's going on. He gets prepared to view the images, and then once he does, he gives that report immediately. Some things that I think could have improved the scan would be if we had a better IV location, obviously, as that hotline has been seen in all of those pictures. It would look a little better and be a little better if we had a peripheral IV to use, but, I mean, sometimes you just have only one line that's available, and that's what you have to do. Another thing would maybe just be to start the flow a little earlier. Some optional things that you could do to improve your scan that were listed on our protocol at Banner University was when using that blood pool image and processing, you can actually kind of place paired regions of interest over the left and right cerebral hemispheres to gather information if let's say half of it was kind of perfused and half of it wasn't. And then you can generate time activity curves over the flow. But I think the images that we got were enough information that we needed for this specific study. This is the article that I posted on the discussion board for my case study. This is just kind of an article describing the benefits of having both CT and nuclear medicine images for brain death studies, especially because the scintigraphy aspect of it really helps with the cerebral perfusion, looking at the function, and really evaluating that brain death versus the CT that really just shows the anatomy and shows the location of the injury. So having both together can definitely help with predicting outcomes. I think these cases are interesting in the fact that you're coordinating with different teams, you're coordinating with transport, you're coordinating with the nurse teams that have to come down and the respiratory. All of these people have to come down for this patient, and you have to make sure that you're prepared. And the images are interesting to look at. Although I know that all of these patients coming down come in grave situations, and the reason that they're down there is definitely not bright and happy, but it is something that you have to encounter in the hospital setting. So it's definitely an interesting thing to know about and something that you should be able to do, especially if you work in a hospital. And these are my sources. Thank you for viewing my presentation, and have a wonderful rest of your day.